All right, the topic for this lecture is going to be osteoarthritis. So why are we covering osteoarthritis? Well, first, it is the most common disease you're going to see when you read bone films. And for patients, it's a big source of both morbidity and disability. Now, why do we image patients with osteoarthritis? First, to make a diagnosis, and we'll talk about how we do that. Second, to plan how we're going to treat a patient, and that can be both operative and non-operative. Third, to look for complications of osteoarthritis that may be forming part of the symptoms. Now, we do get a lot of follow-up films for osteoarthritis looking for progression. This is probably not a great use of it, and that's because how severe osteoarthritis is radiographically really has no correlation at all with how severe it is clinically. So once a patient has osteoarthritis, we don't decide, well, you need a hip replacement now because your x-rays look this bad or have gotten worse. We decide it simply on how much pain you're having and can you tolerate that or not. So what is osteoarthritis? This is degenerative joint disease, specifically degenerative joint disease of synovial joints. Now, some people would complain that this is not a great term, osteoarthritis, and would say we should call this osteoarthrosis, but it turns out all these patients do have at least low-grade inflammation, so the term itis is correct. And if you talk to patients with osteoarthritis, like this patient who has it in their fingers, and you ask them what bothers you, it's not just the pain, but this guy will say, well, every couple months, this particular joint will get sort of red, hot, and swollen. He's describing inflammation. He says, then that gets better and another joint sort of acts up. So there clearly is inflammation. This is not, as we used to think, simply wear and tear, and it's certainly not part of normal aging. Normal joints are not supposed to wear out over your lifetime. Now, this is a disease that really starts in the cartilage. So if you want to argue that this is a misnomer, it's not the itis part, it's the osteo part. This really should be called chondroarthritis or something like that. But we still call it osteoarthritis. And note that as bad as it is on radiographs, it doesn't have to be symptomatic. So this is the outline I'm going to follow. We're going to talk about the different findings of osteoarthritis, and I'm going to emphasize those that are specific for you to make a diagnosis. Once we make that diagnosis, we're going to decide is this primary or secondary osteoarthritis, and we're going to do that based on the distribution of the disease. For primary osteoarthritis, there's two special subtypes we'll talk about, erosive and rapidly destructive bone disease. For secondary osteoarthritis, to figure out what the underlying cause is, we're going to determine, does it affect one or two joints or many joints? And then finally, at the end, I'll talk about some of the complications that occur both in primary and secondary osteoarthritis. So what are the findings that tell us someone has osteoarthritis? And there's really two important ones. The first is non-uniform joint space narrowing. Now notice I said non-uniform, not asymmetric. Asymmetric means right and left. When we say uniform, I mean within one joint, part of the joint's involved and part of the joint's not. Now, what is the joint space? It's not a vacuum. There's something between the two bones, and that something is hyaline cartilage. Now, that's invisible radiographically, which is probably why historically this was called a joint space. But when we're losing that joint space, it's the cartilage that we're losing, and the cartilage thins primarily in the pressure zones of the joint first. And for that reason, X-rays made with weight bearing are going to be more sensitive for joint space narrowing than those made without weight bearing. So here's a patient with knee osteoarthritis. We're looking at joint space narrowing. It's non-uniform. In the medial compartment, it's very narrow there, less narrow there. It's also non-uniform throughout the whole knee joint. It's more in the medial compartment than in the patellofemoral, and the lateral compartment in that case was spared. Now here's a patient with osteoarthritis, two different radiographic projections. On the AP examination, the joint space looks pretty normal. On this projection, a tunnel projection where the knee is a little bit flexed and the beam is angulated, notice now we can see that joint is actually a little bit narrowed. But look at this, in what's called a Rosenberg projection, now not only are the knees flexed, but the patient is standing. And now we can see that in reality, there's almost no joint space there at all. Well, how do we explain this? Well, it turns out in the knee that the first area in osteoarthritis that we lose cartilage is not straight in the middle, but rather posteriorly back here. So on this knee MRI, this is where we've lost all our cartilage. So when the patient is standing, what we're looking at is the cartilage that's still there. So this black and gray stuff here is the cartilage that's giving us the joint space that looks normal. When the patient flexes their knee and then when they weight bear, this part of the bone moves here. And so now what we're seeing is less cartilage against that surface and more joint space narrowing. So here's a patient with osteoarthritis of the hip. Again, it's non-uniform joint space narrowing. In this particular case, the part of the hip that's involved is the superolateral part of the hip where we have all that narrowing here. Now, it looks like this hip is laterally subluxing, but that's not true. All we're seeing is a manifestation of there's less cartilage here than everywhere else. Just like this patient does not have lateral subluxation of their patella. The patella is sitting over laterally because we've lost all this cartilage here and none of the cartilage here. So there's just less space here and it looks like it's moved. Now, if we think about the hip joint, where the hip moves is going to depend on where we've lost the cartilage. So superolaterally here, but we could have also lost cartilage superiorly or inferomedially or medially or even superomedially. Now, if we think about superomedial cartilage loss, if that's where it is, where is the hip going to move? And it's going to move axially. So here we have a patient with osteoarthritis. It's a non-uniform joint space narrowing, severe here, normal everywhere else. And it looks like the hip has then migrated axially. But this is osteoarthritis, non-uniform joint space narrowing. So there is nothing magical about axial migration of the hip that says this has to be an inflammatory arthritis. This absolutely happens with osteoarthritis. So why does everyone say, well, this is characteristic of an inflammatory arthritis? Well, here's a patient with rheumatoid arthritis. What's happened here is we've lost uniformly all the cartilage, okay? And if we do that, the hip will move along its long axis, which just coincidentally happens to be axially as well. The second major finding is osteophyte formation. And really, this is the earliest finding we see in osteoarthritis. It happens in the non-pressure zones of the joint. And this is metaplastic tissue that undergoes chondrogenesis and then eventually bone formation. My definition of an osteophyte is its reparative bone outgrowth from the edge of a normally shaped articular surface. And that's going to be an important definition when we're trying to distinguish is something an osteophyte or something not. And the term osteophyte really should be reserved for patients with osteoarthritis. It's a much more specific term than what you'll hear sometimes called a spur. So here's two different patients with osteoarthritis in the shoulder and the hip, and these icicles that are hanging down off of the edge of an otherwise normally shaped bone are osteophytes. Now here's a patient with osteoarthritis of the distal interphalangeal joints of the fingers. These are narrow, but you'd say, where are the osteophytes? And the answer is you're looking right at them. They're superimposed. You're looking at them en face. On the lateral examination, you can see they're humongous osteophytes here in profile, and they're sitting right on top of the bone here on the PA examination. So when we look at the fingers and we look at the toes, you have to use your lateral examinations to find your osteophytes. What do small osteophytes look like? Where here's a patient with osteoarthritis of the STT joint, the triskephy joint. There's our non-uniform joint space narrowing. These are small osteophytes. So the body makes rounded corners, okay? As soon as you start seeing sharp corners, that's the beginning of osteophytes there. Now, what about this patient with knee osteoarthritis? Here we have an osteophyte off the edge of the bone. That's fine. But what is this thing sitting right in the middle? This is an intra-cartilagenous osteophyte. So if we look at this patient's MRI, we can see that they've had full thickness cartilage loss right in the middle of the articular surface, and it's healed with new bone growing into that. Now, this still meets our definition. This is still an osteochondral outgrowth from the edge of an otherwise normally shaped bone. Now, I said osteophytes and spurs are probably two different things, and I reserve the term spur for something like this, an olecranon spur or a heel spur. This has absolutely nothing to do with osteoarthritis. It has absolutely nothing to do with the joint at all, but these enthesopathic type changes may or may not be symptomatic, but these should be called spurs. The ones that are result from osteoarthritis should be called osteophytes. So what about this? So here's a patient now. We're looking at the metacarpal phalangeal joints, and I see these sharp edges. Are these osteophytes or not? And the answer is no, these aren't osteophytes. Why not? These are not extending beyond the edge of the normally shaped bone. What this is a patient with 4+ erosions. This is a patient with rheumatoid arthritis. Big holes have been taken out of the bone, and what you're looking at here is the bone that's left behind. So if we look at a typical metacarpal phalangeal joint that looks like this, and we say, well, we're going to add in erosions. We're going to take away some of the bone here. Look what happens when we take that bone away. We're left with these little edges that look like sharp points, except they're not extending beyond the edge of where the normal bone was. So these are not osteophytes. Now, there's a bunch of other findings that people will describe with osteoarthritis, and we're going to go through each of them. I ignore all of them. And why is that? Because even though they occur, they are not going to help you make a specific diagnosis. So let's start with subchondral cyst formation. Cysts are not specific. Here's two different patients with hip disease. In this patient here, what is this disease? Osteoarthritis. Why? Not because there's a cyst, but because there's non-uniform joint space narrowing. This patient does not have osteoarthritis. Why? Because the joint space is perfectly normal. There's no osteophytes here at all. This is a patient with osteonecrosis. Two different patients now. How do you tell if these are cysts or erosions? So we have big holes inside the ends of the bones. Is it by how big they are, or whether they're sharp, or whether they're sclerotic? And the answer is no. These can be erosions or cysts. So how do we tell? We ignore them. We look at everything else. So in this patient, what do we see? Uniform joint space narrowing, no osteophytes. Therefore, this is not osteoarthritis. This is an inflammatory arthritis. This is a patient with rheumatoid arthritis, typical erosions, and these are all erosions, not cysts. What about this patient? Well, here, that joint perfectly normal. This one uniformly narrow, but no joints with non-uniform narrowing, no osteophytes. This can't be osteoarthritis either. This patient actually has tophi here, and this is a patient with gout. So when someone asks me, how do I tell the difference between an erosion or a cyst? What I tell them is I put my hand over it. I just ignore whatever that hole is, and I look at the rest of the joint. If the rest of the joint shows non-uniform joint space narrowing and osteophytes, it's osteoarthritis. I take my hand away, and I call that thing a cyst. If I put my hand over it and the rest of the joint has uniform narrowing, no osteophytes, it's an inflammatory arthritis. I take my hand away and I call that erosion. So it's not what it looks like, it's what else is going on in the joint. So that's not useful. What about this? Subchondral sclerosis or eburnation. Sclerosis in this case means white bone. That's not specific either. Here's a patient with very white bone, but doesn't have osteoarthritis. The joint space is normal. There's no osteophytes. This is a patient with osteonecrosis. Here's a patient where all the bones look very white, but in this case, we have very uniform joint space narrowing and erosions. This is not sclerosis. This is a patient with an inflammatory arthritis and psoriasis. Even in patients with osteoarthritis, when you say there's sclerosis, you're usually going to be wrong. It's not whiter bone, it's more bone. So here's what I mean. This is a patient with osteoarthritis of the first carpometacarpal joint. Very, very common location. And you would say, well, look, there's sclerosis. That's extra white bone. But what we're seeing here is simply overlap. There's a huge osteophyte here. And when you look at it on the PA examination, you're just seeing that osteophyte superimposed. There's no extra whiteness in the bone. There's just more bone here. So sclerosis is not useful. What about articular surface collapse? Guess what? Non-specific. So here we have this part of the bone is collapsed, in this case due to osteoarthritis, non-uniform joint space narrowing. In this patient, we have collapse of the humerus, but the joint space is perfectly normal. No osteophytes. This is not osteoarthritis. This is a patient with osteonecrosis. Now, there is one form of osteoarthritis where the amount of collapse can be very profound. So here's a patient clearly has osteoarthritis, right? Non-uniform joint space narrowing looks okay here, but look at what they look like 16 months later. At this point, the predominant finding now is collapse, that we have lost a lot of bone. And this is a type of osteoarthritis called rapidly destructive disease, or rapidly destructive osteoarthritis. And this is a subform that occurs mostly in older women, most commonly in the hips, though occasionally in the shoulders or other joints. It's characterized by very rapid clinical progression. So these patients will go from having symptoms to needing a joint replacement in a year and a half, compared to most patients where that might be 8 to 10 years. It's characterized by profound bone and joint loss and collapse and very little osteophytosis, probably because it happens so quickly. And these can be tricky. These can look like a septic joint or neuropathic. So in a lot of cases, we end up aspirating these to make sure that it just is osteoarthritis. And then finally, you'll hear people say that normal bone density is part of osteoarthritis. In other words, there's no osteoporosis. If you have osteoporosis, that has to be another disease like an inflammatory arthritis. That's not specific either. Here's a patient clearly has osteoarthritis. This one was due to a rotator cuff tear, but we have narrowing of the joint non-uniformly, osteophyte formation, osteoarthritis. But these bones are pretzel sticks. I mean, this patient has almost no bone stock left, severe osteoporosis. On the other hand, here's a patient whose bones are super thick. I mean, these metacarpals are Louisville sluggers, yet they have erosions, no non-uniform joint space narrowing. This is a patient with rheumatoid arthritis who happens not to have osteoporosis. So whether or not you have osteoporosis really depends on whether you're continuing to use your joint or not necessarily on whether you have osteoarthritis or another form of arthritis. So that's not useful either. There's one other form of osteoarthritis we should talk about, and that's called erosive or inflammatory osteoarthritis. Again, this is mostly a condition that occurs in middle-aged women, and it's where the inflammatory symptoms predominate. So we said that all patients with osteoarthritis really do have some inflammation, but in these particular patients, the inflammatory symptoms are profound. Now, classically, it's said that these patients have central erosions radiographically, and that is true. However, if you look at MR or ultrasound, that 80% of patients with osteoarthritis, all patients, not just these with erosive osteoarthritis, have typical marginal erosions. They're just too small for us to see radiographically. One condition that this may lead to, though, is ankylosis. So here's a typical patient with erosive osteoarthritis, middle-aged woman. We can see it's clearly osteoarthritis. There's our osteophytes, but notice how many erosions we have as well. This is typically a disease in the PIP and DIP joints of the fingers, often very symmetric as well. So everything I've shown you so far has been an example of primary osteoarthritis. Primary means there's no obvious underlying cause, but of course there are risk factors. Some of those risk factors include your family, genetics, so this tends to run in families. Older patients, women more than men get osteoarthritis. Patients who are obese, not surprisingly, get more osteoarthritis, although this is strongest in the knees. It's not clear, frankly, whether obesity leads to hip osteoarthritis or not. Patients who use their joints a lot can get osteoarthritis, but also underuse of the joints can result in osteoarthritis. So sedentary patients can also develop it. There are some subtle anatomic features where your bones are just a little bit misshapen that may predispose you to osteoarthritis. That's one of the arguments made for a condition called femoroacetabular impingement in the hip. And believe it or not, this is the only disease I know that actually smoking prevents you from getting. So non-smokers, for reasons unknown, get more osteoarthritis than smokers. Still probably not a great reason to take up smoking, though. How do we recognize primary osteoarthritis? It's by distribution. I've shown you that distribution. So in the hands, we're looking at osteoarthritis, non-uniform joint space narrowing and osteophyte formation. In the PIP and DIP joints, out of proportion to the MCPs. In the wrist, typically just in the first carpometacarpal joint and the triscaphe joint, so the basal joints of the thumbs, not in the radiocarpal joint. In the feet, typically only in the first metatarsal phalangeal joint or between the first metatarsal and the underlying sesamoids, not in the hindfoot, not in the midfoot. In the knees, typically in the medial or lateral compartments with or without the patellofemoral compartment. The big joints of the body, especially the hips and shoulders, though important exception, elbows and ankles typically do not get primary osteoarthritis. The joints that are lettered, and by these I mean these joints, the acromioclavicular, sternoclavicular, sacroiliac, temporomandibular joints, and then finally in the spine, the synovial joints that are the facet joints, uncovertebral joints, and the joints between the C1 and C2. Now, if we see osteoarthritis in a different distribution than what I just told you about, that's our clue that this patient has secondary osteoarthritis. And I think about this in this way. A patient can have secondary osteoarthritis maybe in one or two joints, or they can have it in multiple joints. If it's in one or two joints, you're thinking something happened to this joint. It can be that the surface is incongruent. Maybe they had a fracture or collapse from osteonecrosis. It could be that that joint had a prior insult. Maybe it had sepsis before it was infected, or has gout, or there was bleeding in it. Or it can be something wrong with the way that joint functions, for example, neuropathy. When we see multiple joints involved, the first thought is maybe the patient has an underlying inflammatory arthritis like rheumatoid arthritis. They've worn out all their cartilage and they're getting secondary osteoarthritis. It could be due that they're getting osteoarthritis in an unusual location because of their sport, occupation, or some sort of overuse. Or it could be that they have a generalized disease that weakens cartilage, and we'll talk about some of those CPPD and some syndromes. So here's a patient with osteoarthritis, non-uniform joint space narrowing, and osteophyte formation, but in an unusual joint in the ankle. This has to be secondary, and here we can see what it's secondary to. They had prior intra-articular fracture of the distal tibia and a fracture of the fibula. They've actually formed a synostosis, and if you want to know what that is, you can listen to the lecture on abnormal fracture healing. Here's a patient with osteoarthritis, again, non-uniform joint space narrowing, osteophyte formation, but in an unusual joint. This is the elbow. That's because there's been an insult to this elbow over and over again. There's been multiple times that this patient has bled into this joint, and this is a patient with hemophilia. Here's a patient who certainly has osteophytes, but boy, they're not very big compared to how much joint space narrowing there is. And notice that the joint space narrowing is absolutely uniform. This is your clue that this is osteoarthritis secondary to an inflammatory arthritis. The inflammatory arthritis resulted in the uniform joint space narrowing. The osteophytes came second, and that's what this is. This is a patient with rheumatoid arthritis of the elbow who's developed secondary osteoarthritis. Now, here's a patient with osteoarthritis in a very unusual distribution. The radioscaphoid joint, the capitolunate joint, and the metacarpophalangeal joints. A very unusual distribution for primary osteoarthritis, but a characteristic distribution for secondary osteoarthritis due to either CPPD arthropathy or hemochromatosis. And to talk about CPPD, we probably need to talk a little bit about calcium pyrophosphate. That's the CP of CPPD. And calcium pyrophosphate can affect the body in a few different ways. The first is macroscopic deposition inside cartilage. This is a radiologic finding that we call chondrocalcinosis. It's macroscopic. We see it in the wrists, menisci, symphysis pubis, for example. By far, the most common cause of chondrocalcinosis is simply normal old age. Think of all those old ladies' chest x-rays you've read, and they have calcified bronchial trees. That's all chondrocalcinosis within those calcified cartilages. The second most common cause is going to be an abnormal calcium phosphate product, for example, patients with renal failure, and they're both going to be more common than CPPD arthropathy. CPPD arthropathy and hemochromatosis are diseases where we get secondary osteoarthritis in a particular distribution. Metacarpophalangeal joints, radiocarpal joint, patellofemoral joint out of proportion to the rest of the knee, talonavicular joint in the hindfoot. This is due to microscopic deposition of the same crystals in the cartilage that weaken it. They may or may not have macroscopic deposition that is chondrocalcinosis as well. And then we have a third disease called pseudogout. And as this sounds like, this is a disease that mimics gout. So a patient will have an acute flare of one joint, an acute synovitis. Again, it's due to microscopic crystals that have formed inside the joint, they may or may not have chondrocalcinosis as well. So here's an older patient, actually asymptomatic here, but they have extensive chondrocalcinosis here in the menisci of the knee. Here's a patient who doesn't have any chondrocalcinosis, but has patellofemoral compartment osteoarthritis way out of proportion to anything in the medial or lateral compartment. Even without seeing chondrocalcinosis here, we would say this is due to CPPD arthropathy or hemochromatosis. Here's a patient without joint disease or symptoms at all, but they have extensive chondrocalcinosis in the menisci and the hyaline cartilage, even in the proximal tibiofibular joints. And this patient was only 35 years old, clearly not due to old age, but this patient has an abnormal calcium phosphate product, and this was their only manifestation of hyperparathyroidism. And then finally, we have this patient who has a hot joint. Their hip acutely is inflamed here. They might have a little bit of chondrocalcinosis, but this sounds like a septic joint. We went ahead and aspirated it, but instead of pus, what we found was this: these calcium pyrophosphate microscopic crystals in the synovial fluid and inside the white cells, and this is a patient with pseudogout. And then finally, we have a patient like this who has osteoarthritis, an unusual distribution, multiple joints. Now we would say that there's probably some syndrome going on that's weakened the cartilage all over the body. Acromegaly would be one such syndrome. This patient had a strange disease called Stickler syndrome, which does the same thing. And then finally, I just want to spend a minute talking about complications of osteoarthritis. And this happens in both primary and secondary osteoarthritis. The complications we see are loose bodies, lost motion, and deformities and malalignments. So these are loose bodies in the knee. The patient has osteoarthritis, non-uniform joint space narrowing, osteophyte formation, but they have all these things inside the joint. Some look like boulders, some are laminated, some look like snowflakes. These are loose bodies. Where did these come from? Well, we said that in osteoarthritis, the cartilage thins because we shave off little microscopic pieces of cartilage. That's inside the joint now. Now, sometimes that's just crushed down into dirt and is resorbed, but sometimes that piece of cartilage will float around, reattach itself to synovium, and develop a blood supply. Once that happens, a couple different things may occur. It may simply resorb and go away. It may sit there and calcify or ossify, or it may start to grow like a piece of bone. And these can grow huge inside the joint. So these did come from the articular surface, but when they came from the articular surface, they were microscopic. So you don't want to look at a loose body like this and say, well, I'm looking for the donor site. The donor site is microscopic. You're not going to be able to find it. Now, these are called loose bodies, even though that we said they may not be technically loose inside the joint. They may be attached to synovium. They're called loose because they originated because they came loose from the articular surface originally. And once they're in the joint, they can go wherever they want inside the joint. So, for example, here in the posteromedial joint, these are far posterior, and these are actually in a patient's Baker cyst. Now, it turns out almost paradoxically that these big loose bodies usually don't give symptoms. What happens is small loose bodies do, because they can get caught between the moving bones. So here's a patient in the elbow who has intermittent locking, and it's due to this tiny little loose body here in the radiocapitellar groove that's getting stuck between the bones as the patient moves. This is a patient, another elbow, who has decreased extension, and they have osteoarthritis. Now, anteriorly, they have a lot of big loose bodies, but those aren't going to prevent the patient from extending. What is going to prevent the patient from extending is loose bodies that are hiding here in the olecranon fossa, or perhaps osteophytes themselves. The osteophytes posteriorly are bumping against those loose bodies posteriorly and preventing the patient from fully extending. Here's a typical location where osteophytes can block motion. So here's a patient with osteoarthritis, severe, of the first metatarsal phalangeal joint space narrowing, and these absolutely huge osteophytes dorsally. As you can imagine, it would be very hard to extend this joint, and extending that joint is the very last stage of walking right before you push off. So these patients have a lot of trouble walking and develop a very rigid great toe, or what we call Hallux Rigidis. So this is a case where we may actually shave off those osteophytes to help the patient. Now, that does not fix the underlying disease. The underlying disease is cartilage loss and osteoarthritis. That may be painful. However, shaving off those osteophytes An operation we call a chelectomy may give the patient improved motion. And then finally, osteoarthritis can result in deformity, and we've talked about that a little bit with the non-uniform joint space narrowing. But here, a patient with knee osteoarthritis, primarily in the medial compartment, we can see they've developed this mechanical varus deformity. Here, a patient with post-traumatic osteoarthritis of the ankle, also with a varus deformity. In this case, not clear whether the varus came first, the osteoarthritis came first, or one is feeding off the other. So to summarize, there's specific and non-specific findings of osteoarthritis. The specific findings are the ones that I concentrate on. That is non-uniform joint space narrowing and osteophyte formation. These other findings may be present, but are not going to help you make a specific diagnosis. Primary osteoarthritis we recognize by its distribution: the interphalangeal joints of the fingers, the basal joint of the thumb, the first MTP joint in the foot, the large joints in the body, and the letter joints in the body, with the exceptions of the two large joints, the elbows, wrists, and I guess the ankles as well, 3. Secondary osteoarthritis we recognize by other distributions, and we want to decide, is that one joint or two joints where there's been an insult to that joint, or is it multiple joints where there's a generalized condition weakening the cartilage? And then finally, the complications of osteoarthritis are important. We see those both in primary and secondary osteoarthritis.